So good afternoon, everybody, and welcome to this third in our series of webinars. Today, we're going to be discussing pigmented lesions. Just before I start, a quick bit of housekeeping. You'll notice in your menu bar, you have a little bubble that says chat underneath it. That's only to be used if you're having some kind of a technical issue, i.e. you can't see the screen or you can't hear the sound. If you move along the bar to where you have the three dots where it says more, if you click on there, you'll find a Q&A box. And if you do have any questions, that's where you type in your questions, and then we will answer the questions at the end of the presentation. So the agenda for the next hour or so is we're going to look a little bit at the anatomy of the epidermis, then look at what is melanin and how it's produced, the different types of pigmented lesions you may well come across in your practice, how we treat those pigmented lesions with light-based technologies, and then a quick summary at the end. So looking at the functions of the skin has a number of different functions. It provides a protective barrier. It helps with the immune system. It regulates temperature. It has some effect on senses. It's an area where we store various different vitamins, etc. Synthesizes vitamin D. And the area that we're really going to focus on today is protection from UV radiation. Three layers of the skin, I'm sure you're all aware. The epidermis, which is where we're going to be concentrating today. Then the dermal layer, which comes underneath the epidermis, which is made of dense connective tissue. This is where you have blood vessels, hair follicles, sweat glands, etc. And finally, the deepest layer is the hypodermis. And this is mainly composed of loose connective tissue and fatty. Looking a little more in depth at the epidermis itself, this is made up of a number of different layers. So starting at the base, we have the stratum bacilli, then we have the stratum spinosum, then the granulosum, then the lucidum, and then finally the stratum corneum. And as the cells are produced, they will migrate through these different layers from the basal layer right through to the top layer, the stratum corneum, where we have the dead cells, which then shed in time. Just looking at very quickly at the different types of cells that we have within the epidermis, we have keratinocytes, and these basically originate from the basal stem cells, and these are the ones that are continually maturing from that basal layer up to the stratum corneum, and then eventually they shed off when they get to the stratum corneum. Melanocytes, this is where we're going to focus our attention today, and this is where the melanin is synthesized, which obviously gives us the color of our skin. There are also two other types of cells within the epidermis, the Langerhans cells, and these help us with antigen presenting cells, and finally the Merkel cells, and these act as the mechanoreceptors that help with sensory perception. So let's look a little bit more at the whole subject of pigmented lesions. So there's a number of things we need to think about here. First of all is melanin, which is, as I mentioned before, is responsible for the color of our skin and our hair. Then we have melanosomes, and these are what are called organelles, and they're responsible for actually creating the melanin. And the melanin is actually, the melanosomes sit within the melanocytes. And if you look at the image on the right hand side, you'll see that that melanocyte has all these fingers, for want of a better term, which are, we call these dendritic structures. And basically when, excuse me, the skin is exposed to ultraviolet light, the melanosomes, which as I said before, are sitting within the melanocytes, they start to produce melanin. And this melanin is then transported via these dendrites, these fingers, into the keratinocytes. And then what happens is you end up with pigment within these cells, and then these cells will then slowly migrate through the different layers of the epidermis until they reach the stratum corneum, when they die off and then they shed. And this process takes between 14 and 28 days from the new cell being formed to the dead cell shedding up at the stratum corneum. All humans have approximately the same number of melanocytes, so the cells that have the ability to produce the melanin. But the difference is in how much melanin is actually produced, and this is affected by a number of different things. It can be the amount of ultraviolet radiation that the skin is exposed to. So obviously, the more sun exposure, the more melanin is produced, so the darker the skin becomes, hence why we get a suntan. Secondly, genetic makeup. So different ethnic groups have different genetically predisposed features that mean that they produce more melanin than other ethnic groups do. And this is due to inheritance. And finally, in some cases, the size of these melanocytes, these cells, can be larger. And in these individuals, it may lead to a difference in the amount of melanin that is actually produced in each one of the cells. So if the melanocytes are larger, they tend to produce more melanin. So what are the causes of pigmented lesions? These can either be hereditary or acquired. So a couple of examples of hereditary would be nevus of Otter or café au lait. And on the acquired side, the causes of these acquired pigmented lesions, a number of different things. It can be a hormone imbalance, it can be due to pregnancy. Some medications will actually cause an increase in melanin production. The menopause again, and that's partly due to the hormone imbalance. And finally, and the most common reason for increase in melanin within skin is sun exposure. So exposure to ultraviolet light. So laser treatments of pigmented lesions. Let's have a look at what we've got here. So if we think the broad classification of pigmented lesions, they can either be epidermal, they can be dermal, or they can be a mixture of both the epidermal and the dermal. Examples here of epidermal pigments. So we can have lentiginous, we can have lentigos, freckles, or café au lait. So these pigmented lesions are all sitting very superficially in the epidermal layer rather than either in a mixture or deep down into the dermis. Dermal pigment, as you can see, tends to be much darker in color. So examples of this would include nevus of Ito, nevus of Otter, or a blue nevus. So these are sitting much deeper in the skin, down in that dermal layer. And the other area we have is where we have a mixed component of pigmented lesions. So here we have some of this pigment which is in the epidermis, and another portion of it is actually sitting deeper down in the dermal layer. Melasma is a prime example. It is possible to have purely epidermal melasma, but this is fairly uncommon. Generally, you find it's a mixed component, and this is why historically, it's always been a very difficult condition to treat with a laser or an IPL machine. And the other option would be a nevus spillus. Again, historically quite difficult to treat because of the fact that you have pigment sitting in two different layers within the skin. So how do we treat a pigmented lesion? Before going to the treatment, we have to ensure that we're actually diagnosing whatever that pigmented lesion is correctly. So think about whether it's sitting in the epidermis, the dermis, or a mixture of the two. And vitally important, just to ensure that the pigmented lesion you're going to treat is benign and not malignant. And if you're unsure of whether it's benign or malignant, always obtain specialist opinion before you treat. So melanomas, obviously, we do not treat melanomas. And one way to have an idea of whether the pigmented lesion you're looking at is a melanoma. Melanomas tend to have irregular borders, or when you take the history from your patient, there's a change in the shape. They can be raised, and also they have an irregular color throughout that lesion. So here is an example of a melanoma. So you can see it's got an irregular border, and there is a little bit of difference in the color within this particular lesion. As they move on and progress, you can see now that differentiation is becoming more obvious. Very irregular borders and much more difference in the color between within that lesion itself. And another example here. So if you see a pigmented lesion that looks anything like this in one of your patients, unless you have 100% confirmation, I would strongly suggest that you get a second opinion to confirm that this is actually a melanoma, in which case you're not going to be treating it. So we've now decided that the pigmented lesion we want to treat is benign, it's not malignant. So we now know it's safe to carry on and treat it. And we can do this in a number of different ways with lasers and IPL systems. We can use nano or picosecond lasers. We can use long pulsed lasers. So for instance, an Alexandrite 755, a 1064, ND-YAG, or even a 1940 diode Frax. Excuse me. Generally, at least 2 treatments are required, sometimes 3, depending on the lesion that you're treating. And our other treatment option would be intense pulse light. And again, several treatments are required when you're treating with an IPL system. So let's look a little bit more specifically about the mechanism of these different types of lasers. If we're using a nano or a picosecond laser, what we're actually doing here is we're using a photoacoustic effect, which is a shock wave with minimal amount of heat. And the amount of heat produced reduces when these picosecond in particular pulses become shorter. And what we're doing here is we're using this acoustic shock wave to actually break up the melanin in the tissue, and therefore it can either be shed or it can be reabsorbed by the phagocytes. Long pulse lasers, this is where we're using the principle of photothermolysis, so we're actually using heat. And you tend to see post-treatment crusting, and then this pigment is eliminated as it moves through the different layers of the epidermis. So specifically, we'll look at the lasers and the IPLs first of all. So as I mentioned just now, long pulse lasers. So typically using a 755, 1064 or a 1940 wavelength. And within the Candela portfolio, the GentleMax Pro is the system that we would use for pigmentation when we want to use an Alexandrite. One advantage of looking at a Gentle Pro system is it can be a dual wavelength laser. Its commonest use is in laser hair reduction. And with the 755, we're treating lighter skin. And with the 1064, we're able to treat darker skin up to skin type 6. And our Alexandrite is also the wavelength that we prefer to use for the majority of pigmented lesions. And we can use the 755 for vascular lesions, particularly in lighter skin types. But in general, for the majority of vascular lesions, we would use our 1064. So how does the Alexandrite, the 755, actually treat these pigmented lesions? We're using a long pulse, so 3 milliseconds, which very closely matches the thermal relaxation time of the melanocytes. So we heat up the melanocytes, which obviously then causes the thermal damage, and this is enough to actually remove these types of lesions. So we're destroying the melanocyte and the melanin it's producing. And it does this by actually targeting those melanosomes that sit within the melanocytes. If you remember, I was saying earlier that the melanosome is the structure that actually produces the melanin within the melanocyte, within that cell. So what you normally find when you treat is you fire your pulse onto the pigmented lesion and the lesion will actually become darker, and then it will produce a microcrust. And over the course of between 7 and 10 days, this microcrust will slowly come away, and then the pigment underneath will be lighter. We don't use any cooling when we're treating with the Alexandrite. Because the lesion is sitting superficially in the epidermis, if we were to cool the epidermis, we would then potentially need higher fluence and therefore more heat in order to get to that heat threshold to actually destroy the melanocytes. So we would, in effect, be fighting against ourselves if we were trying to do that by cooling the skin. Just remember that there are certain pigmented lesions that are unlikely to respond to the 755, the Alexandrite. One being nevus of otter or Ito, and I showed you examples of that earlier, or the melanocytic nevi. And these again are because these particular pigmented lesions sit deeper within the tissue, so they're either mixed or they're sitting in the dermal layer. And the Alexandrite isn't able to treat that deep into the tissue. So once we get to the dermal layer, we then have to look at a different wavelength. It is possible in some cases, particularly with nevus of otter, to use the 1064 on the Gentle Pro series. However, I feel the pulse duration is probably slightly too long, even at 3 milliseconds. So as I go through the presentation, I'll give you other options of how we treat these particular lesions. So treatment technique, we're only looking at treating skin type 1 to 4 with our Alexandrite. We turn the cooling off. Multiple treatments, 2, and possibly, depending on the lesion, 3 treatments. And one of the nice advantages with using the Alexandrite on the Gentle Pro series is you can actually use different spot sizes. So if you're treating a fairly small pigmented lesion, you have the ability to choose a smaller spot size, And if you're treating a larger pigmented lesion, conversely, you can increase the spot size so you're treating a bigger area more quickly. When you're treating individual lesions, it's important to actually isolate that lesion prior to treatment. And you can do this in a number of ways. You can either use a white eyeliner pencil and in effect shade out the surrounding skin around that lesion, or you can cover the surrounding tissue with wet gauze, or you can cut out from a piece of white paper a little template the shape of your pigmented lesion. And what this means then is that you will only get absorption of the energy into the pigmented lesion and not into the surrounding tissue. If you don't isolate the region or the lesion prior to treating, it is possible that you will actually remove some of the pigment from the surrounding tissue around the lesion you're actually trying to treat. And this can then lead to almost like a halo effect around the lesion that you're actually trying to remove. The end point is you want to see that lesion go darker. If the lesion is particularly dark, you will actually hear a snapping sound when you fire the pulse. And again, particularly with darker lesions, you will also see some frosting. And as you can see on the image on the right-hand side, this lesion is definitely gone darker after firing the pulse, and there is a little bit of frosting around the edges of this particular lesion. When you're doing the treatment, you have to be patient. Sometimes you may see in some pigmented lesions that this the lesion you've just treated becomes dark very quickly, but in many cases it can take 3 minutes or 5 minutes before it goes darker. So don't be tempted to fire the pulse, look at it immediately, not see any difference in the color, and then fire a second pulse. One of the common issues when treating pigmented lesions is double pulsing with reasonably high fluencies, and then you end up with potentially a blister or a burn in the area you're treating. So always give it certainly a few minutes, and sometimes it may be as much as 10 minutes before you actually see that lesion go dark. Here we have a lesion that's been treated with the Gentle Pro series. This would have been, I would guess, it doesn't tell me at the bottom here, but probably 3 treatments in order to achieve the clearance of this pigmented lesion. And on the back, again, it would have been at least 3 treatments to achieve this result. And I think the other interesting thing here is when you look at this particular patient, clearly the issue here has been sun exposure, because you can see there is some underlying tan or pigment in the skin. But in the post-treatment picture, we've cleared virtually all of the pigmented lesions, but also the skin color is lighter, which would suggest that the patient is now protecting their skin against the sun and the ultraviolet radiation. So they were heeding the warnings given within the clinic. When we're treating larger areas, for instance, the chest, rather than firing just single pulses, it is possible to set the handpiece up with a higher repetition rate. And what we then do is we do 1 pass across the whole area, but we slightly defocus the handpiece. So we hold the handpiece 1, possibly 2 centimeters above the skin and treat the whole area. It's a much quicker way of treating a very large area with lots of small pigmented lesions, because you don't then have to treat each individual one, you're treating globally. And also you get a very nice even skin tone after the treatment, as you can see in this picture here. So this again would have been 2 or possibly 3 treatments. One thing just to note, when you are doing this this painting technique, as we call it, this area, the chest area, will become very red and it will get very hot. So post-treatment, it's important to cool the skin down, and that erythema may well last for 48 hours. But it will settle down, and then, as you can see, you get very nice clearance of the area. The second system we can use for treating pigmented lesions is our Nautilus. So multi-application system, combination of IPL, and it has a long pulsed Nd:YAG, and it has 2 Frax handpieces as well. Large number of different indications. So today, obviously, we're looking at benign pigmented lesions. In one of our previous webinars, we were looking at vascular lesions and things like telangiectasia, port wine stains, rosacea, etc. And also using the Nd:YAG, we can treat more vascular conditions, so leg veins, so larger vascular structures, venous lakes, port wine stains, etc. And finally, with our 2 Frax handpieces, the 1550 and the 1940, here we can use it for skin resurfacing. And in particular, with the 1940, we can also use it to treat actinic keratosis. So we're using it to treat some pigment as well. The main handpieces for treating pigmented lesions are the IPL handpieces within the Nautilus. And we're using, with different to the majority of other IPL handpieces on the market, in the fact that we have a dual filtering system on these handpieces. So if you look at a standard IPL handpiece, it will give you one cutoff filter, which could be anywhere in the region of 400 to high 600 nanometers as the starting point. So it filters out the light below whatever that number is, but it will carry on delivering that spectrum of light somewhere up into about the 1200 nanometer range. And what this means is that it's actually moving into the area where you start to heat up the water, or the chromophore becomes water. And this is the reason why with a standard IPL handpiece, it needs to have very effective cooling. Because even though we're heating up whatever our target might be, we're also heating up the water in the surrounding cells, which is why the overall area becomes very warm. But with the Ipls handpieces, we have this dual filter technology. So here what we do is we have the starting cutoff filter, which could be, depending on what it is you're treating, anywhere from 645 nanometers up to 600. But we then have a second filter that cuts off the light from either 750 nanometers or 950 nanometers. And the critical point here is we're now cutting off that additional light just before the water becomes one of the main chromophores. So it means that we're heating up our specified target to the required temperature to destroy it, but we're not heating up the surrounding water in the cells in the tissue. And this is the reason why we don't need any kind of contact cooling when we're using this dual filter technology, or SWT as we call it. We have a number of different handpieces within the range, and I've highlighted the handpieces that we use for pigmented lesions. So this could be the VL555. So that means that you have an effective range of light from 555 to 950 nanometers, or the PR530, and here we're running from 530 to 750 nanometers. and the other option is the PL 400, and this will run from 400 to 720. Now, word of caution with the PL 400, because the absorption or the wavelength starts at the 400 nanometer range, this will have a much stronger and more superficial absorption into the melanin. So you have to be very careful when you're treating darker skin with this particular handpiece. And it's primarily used in a lot of clinics to treat acne with the addition of photodynamic therapy. The commonest handpieces used with our Nautilus system for pigments are the VL555 and the PR530. Then we have another two handpieces. So these ones have the annotation of S attached to VL or PR. And this basically means that, as you can see from the diagram in the bottom right-hand corner, rather than having the large surface area of 10 by 48 millimeters in the oblong shape, we now have an hexagon. And this is very useful if you're treating small, very specific pigmented lesions. So rather than using the large applicator and covering a large area of the tissue, we can focus in on very more specific, smaller lesions with the S handpieces. One very nice feature of particularly the Nautilus, but in some other IPL systems as well, is rather than firing a single pulse, as we tend to do with our Alexandrite and our 1064 in the YAG, here we can actually provide a train of pulses. So when we're treating pigmented lesions, we can fire for instance, a 2.5 millisecond pulse. Then we have a delay of maybe 10 milliseconds, and then we fire a second 2.5 millisecond pulse. And this also helps to heat up that pigmented lesion without heating up the surrounding tissue. And depending on the skin type, we will choose the correct handpiece. And also, in another respect, it's also partly down to how dark the pigment is. So if we're treating darker pigment, so eumelanin, we would use the 555 handpiece. This will go a little bit deeper into the tissue, and it will absorb more strongly into that darker pigment. But if we're treating the pheomelanin, we use the 530 handpiece. Because this melanin or this pigment is much paler in color, we need that wavelength because it has a stronger absorption into the melanin. So it gives you that option of using two different handpieces depending on the color of the lesion that you're treating or the darkness of the lesion that you're actually treating. And another consideration when you're doing the treatments, if you're treating the neck or the chest area, then we reduce the fluence by between 1 and 2 joules. And similarly, when we're treating the forehead, we tend to reduce the fluence by maybe 2 joules. The endpoint we're looking for is the same as when we're using our Alexandrite. So we're looking at darkening of that pigment. And if you remember, as I told you just now, it can in some cases take as much as 5 minutes before you see that darkening of the pigment. So you have to be a little bit patient when you're doing this treatment. These are typically the kind of pigmented lesions that we're treating. And as you can see, depending on the color, the pigment that we've got will determine which one of the different handpieces we're going to use. So the darker pigment, we use the VL555. For the medium, the 530, and if it's very pale pigment, we would look at using the PL 400. Here is a typical lesion that's been treated. Excuse me. And here you can see, as we move from the first to the fourth treatment, and obviously one thing you want to see when you're moving through your course of treatments is you want to see that pigmented lesion get lighter. So here, the first 3 sessions they were using the VL555 because the lesions were dark. And as that lesion lightened up before that 4th treatment, the operator switched to the 530 because we wanted to treat the paler, lighter pigment. And you get much more effect on that paler, lighter pigment with the 530 than you do with the 555. Here, so this is, as I mentioned earlier, when you treat the chest area, you get a lot of erythema. So we have the before picture immediately after the treatment, where you can see a lot of erythema, but a month after the treatment, very nice clearance of this pigment. And if you look at the settings used, we have done, it's a double pulse with a 10 millisecond delay between the 2 pulses. And you can, as you get more experienced and you get more comfortable using the system, you can then start changing these pulse durations and you can start changing the delay between these 2 pulses. And here we have a picture where we've been using, excuse me, the Frax handpiece. So again, very nice clearance of this pigmentation. The other option, treatment option that we have within the portfolio is to use our Picoway system. And it's, I think, generally when we first introduced the Picoway, it was mainly used or targeted for tattoo removal, which is pigment, albeit different colors, but it's pigment. But the system can do an awful lot more than just tattoo removal. We can treat benign pigmented lesions, which is obviously what we're going to be focusing on today, but we can also improve acne scarring, reduce wrinkles, and also, as I'll talk about in a moment during this presentation, we can also use fractional handpieces, and this is called Resolve, or the latest handpiece now is called Resolve Fusion. So the difference between the previous 2 systems we were talking about, the Gentle Pro series and the Norless system, we were using heat in order to destroy our pigment. So that laser energy is being delivered fairly slowly into the tissue. And what it means is that certainly the larger particles of pigment fracture due to this thermal stress. However, with a picosecond laser, we're moving away from that thermal effect to a photoacoustic effect. So what we're doing here is, because the pulses are so much shorter, we're actually delivering, in effect, a shock wave, which is shattering the pigment into much smaller pieces, which makes it much easier to remove. And if we look at the chart on the left-hand side, the black vertical dotted line is basically anything to the left of that is acoustic, and anything to the right-hand side of that line becomes heat. So you can see, the shorter the pulse that we're able to deliver in picoseconds, the more of that energy is actually being delivered in that acoustic range rather than in thermal range. And the longer the pulse, the less we have in the acoustic and the more we have in the thermal range. And if we look at that as numbers, if we look at the red, excuse me, the red line on the graph, which is a 450 picosecond pulse using the Picoway, you can see that we're getting 25% of that energy is being delivered within that acoustic area. Whereas if you move to 750 picoseconds, we're now down at 2%. And if you use a 50 nanosecond Q-switch laser, it's less than, well, it's 0.26% is actually sitting in that range. So it's really critical, particularly when you're treating pigment, to be using very short picosecond pulses, because then we're delivering much more of that energy in that stress relaxation time, and therefore giving us that true acoustic effect. And if you then think about a 350 picosecond pulse, this can actually be over 4.5 times more effective than the 750 picosecond pulse, because of the amount of that pulse that's sitting in that acoustic range. So with the picosecond, we have a full range of different handpieces. So we have what we call our zoom handpieces. So this is the 1064. We have a 532, a 730, and a 785. And these, in effect, are full beams of energy. But we also have two fractional handpieces, which are 1064 and 532 nanometers, which is what we call our resolve and our resolve fusion. And the nice thing with this system is, obviously, a large number of our customers are using the Pico to treat tattoos. And because of this broad range of different wavelengths, it allows us to treat virtually every color that you may come across in a tattoo. The only color we can't remove is white. But if you're then looking at treating pigmented lesions, again, all of those different handpieces, the 532, the 730, the 785, and the 1064, can all be used, depending on what the pigmented lesion is, in order to remove pigmented lesions. So it gives you a really broad range of different wavelengths and different handpieces to treat virtually any pigmented lesion you come across within your practice. This is one of our newest handpieces. This is a 730 nanometer handpiece. This is a single beam, and it can either be a 2, 3, or 4 millimeter spot size. This has the shortest pulse, the shortest picosecond pulse on any system on the market, and this is 250 picoseconds. So you remember back to the chart I showed you earlier, where you could see the shorter the pulse, the more of that energy is being delivered within that stress relaxation time, the acoustic range. By moving down to 250 picoseconds, we have a much larger proportion of that energy being delivered within that range. So it gives you a much stronger acoustic shockwave, and we get much less heat within the tissue. It also gives you, if you look at the chart on the left-hand side, it actually gives better absorption into melanin that we get from the 755 Alexandrite. And also importantly, you get very good absorption into the melanin, but the absorption into hemoglobin is much lower. So you're not in a situation where you potentially have a competing chromophore, i.e. hemoglobin plus your melanin. So it targets the melanin, but it has a much lower absorption coefficient into hemoglobin. So this is using our zoom handpiece, the 532 nanometer handpiece that we would use for larger, more demarcated pigmented lesions, as you can see in the image here, and this is after a single treatment. So one of the main differences or advantages of using a picosecond laser to treat a pigmented lesion. It absorbs into the pigment much better, and you generally get a much quicker resolution of that lesion with less number of treatments. Here we're using our 730 nanometer handpiece on these lesions. These are much lighter lesions, so generally can be much more difficult to remove. But here we've got very nice clearance of these after 3 treatments. And there's no downtime for the patient after these treatments. We can also treat post-inflammatory hyperpigmentation. Here we use our Zoom or complete beam 1064 handpiece. Very low fluences, only 0.7 up to possibly 1 joule per centimeter squared. We use a 6 millimeter spot size, a reasonably large spot, and we just do a single pass. And you can see dramatic improvement, and this is only a single treatment. And 2 things to note here: post-inflammatory hyperpigmentation can be an incredibly difficult thing to treat with a laser or an IPL machine. And generally the reason is when we're using long pulses, as in millisecond pulses, we're producing heat. So we use the heat, we deliver the heat into the tissue, which produces more inflammatory response, and generally you find that the PIH becomes worse. But because we're not using anywhere near the same amount of heat here, we don't get the same inflammatory response, but we get very nice clearance of this PIH. And another one here. And this was after 2 treatments, but you can see after 2 treatments, pretty much gone completely. And this would be impossible to do with a longer pulse laser that's delivering all of its energy as heat. Nevus avota, I mentioned this earlier. Historically, this has been an incredibly difficult thing to treat with a laser. But when we use our 1064 Zoom handpiece, you can see after 5 sessions the amount of clearance that we've got here. So significant improvements. And I don't think I have the picture on this presentation, but I do actually have another picture at 7 sessions, and we have even more clearance by 7 sessions. So the other handpieces, or the other technology that we're using on our picosecond laser, on the Picoway, is a fractional handpiece. And we call our fractional handpieces Resolve. And the advantage from the patient point of view is there is low to virtually no downtime when we're using these handpieces. We're delivering the energy as 100 small microbeams rather than one large solid beam. And we're focusing the laser just under the surface of the skin. So we get that high concentration of energy not sitting on the surface of the epidermis, but either deeper into the deeper into the epidermis or down into the dermal layer. And the idea here is by delivering that very high concentration of energy down into the dermal layer, we get what are called laser-induced optical breakdowns. So these are, in effect, tiny little microplasma bubbles in the tissue. And the body's response to that, it sees that as an injury, and therefore it stimulates collagen, or in this case, we're disrupting the pigment within the skin. Also really important to note that when you look at, there are a number of different picosecond lasers on the market that have fractional handpieces. And they all tend to use the system on the left-hand side of the screen here, which is something that's called a microlens array. So what they do here is they put a lens in front of that solid beam, and it has a whole series of convex bubbles in effect on that lens. So that has the effect of splitting that beam up into up to 100 microbeams. One of the issues of using the micro lens array system, you don't get a uniform delivery of the energy across the whole of that treatment area. As you can see from the little inlaid picture on the left-hand side, you're getting higher concentrations in the corners and a lower concentration in the center. The big difference when you're using the Resolve handpiece, because we actually use a holographic lens. So rather than the concave lens to split the beam up, we're actually able with this hologram to break the beam up into 100 exactly equal microbeams. So it means that every single one of those beams is delivering exactly the same amount of energy, and we're not losing any of that energy into the background. Whereas when you look at the micro lens system, you could have a range of between 2.6 up to 11.3 joules per centimeter squared of fluence. And you will lose up to 30% of that energy in the background. Whereas with Resolve, each one of those peaks is the same fluence as the one beside it, and we're not losing any of that energy into the background. So it makes it more efficient, but it also means you get a much more even coverage of the area you're treating. This is looking at that little holograph or holographic lens in the handpiece. So it's producing this 6 millimeter by 6 millimeter square of 100 microbeams. And you can see from the graphic on the right-hand side, it's then concentrating the energy deeper into the tissue and producing these light-induced optical breakdowns. And if we change the wavelength of the handpiece to the 532, it's more superficial. So then we're actually producing our LIOBs in the epidermal layer, and therefore we're targeting the pigment within the epidermis. And this you can just see is the histology showing these LIOBs in the tissue, and then the healing process as well on the right-hand side. So our other new handpiece on the Picoway is the Resolve Fusion. The difference with Resolve Fusion over the standard Resolve 532 is, rather than delivering these high energy single 100 little microbeams, what we're doing is we're still delivering 100 microbeams, but we're giving two different energy densities for each one of those little beams. And it means that we're doing a couple of things. First of all, the center part of that beam is higher energy, higher fluence, so it's penetrating slightly deeper into the tissue. And the ring around it with slightly lower fluence is not going as deep into the tissue, but we're getting a much higher coverage with each pass. So with our Fusion handpiece, the density is 50%. And with the standard Resolve handpiece, the density is only 10%. And particularly when you're looking at treating pigment, diffuse pigment, which you have on the face, for instance, you want a very high density of coverage. So if you're using a standard 532 Resolve handpiece, you would need to do numerous passes to even get to a 50% coverage. Whereas with our Fusion handpiece, 2 passes and we virtually have a coverage of 100%. So it gives you a much more efficient coverage, and also it gives you, excuse me, a much better end result when you're looking at treating pigment, which is exactly what this is saying. This is the kind of results that we achieve. So this is after 3 treatments. So immediately after the treatment, these lesions will start to go a little bit darker. There may be a very small amount of residual erythema, but that settles down very quickly. And as you can see, we get very nice removal of the pigment, but also a very nice even skin tone following the treatment. We don't end up with small areas where we've actually removed more pigment than we wanted to, and so we don't have any areas of hypopigmentation. Again, another treatment here using fusion. It's a very comfortable treatment. And we've done 3 treatments for this patient as well. And similarly here. So in summary, if we're talking or looking at benign pigmented lesions, they can either be epidermal, dermal, or mixed. They can be hereditary or acquired. And as I mentioned at the beginning, the commonest acquired cause is sun exposure. And when using our light-based technologies, we can either use heat, where we're talking about longer pulses, so in the millisecond range, or acoustic shock waves when we're down in the picosecond range. So which system? This is always the biggest question I get asked when I'm in maybe doing a demonstration of a machine. Which machine do you buy? Well, we're giving you 3 different options. You can either use a system that's producing heat, so either the Gentle Pro series with the 755 Alexandrite, or with the Nautilus, where we have 3 different options of IPL handpieces. The results are very, very similar between these 2 systems. 2, 3, sometimes 4 sessions required. And after 7 to 10 days, you get this little microcrust shedding away of the skin. And during that time, it is really important that your patient makes sure that they keep the skin well hydrated. Or the other option is to look at the Picoway. We have numerous different handpieces, different wavelengths. So this allows us to treat an even greater number of pigmented lesions than we can with our Gentle Pro or our Nautilus system. So for instance, we're able to treat, as I showed you, nevus of otter, nevus spillus, and we're even now exploring with a number of different clinicians treating melasma with the Picoway. Melasma, again, has been one of these very, very difficult things, pigmented lesions, to treat with a millisecond pulse laser because of the amount of heat that is producing. And if you treat melasma with a heat generating laser, you're actually going to make the pigmentation worse. But because with our Pico, we're using acoustic shock waves as opposed to bulk heating, we don't get that same level of inflammation, but we are able to break up the pigment in that melasma and resolve it. So that's the end of the presentation. Do we have any questions? Let me see.
Hi, Hamish. I see one question.
Okay.
In painting protocol, what is usually suggest parameter for this?
So it's really easy because when we're using the Alexandrite, we always use a 3 millisecond pulse. So we don't need to change the pulse. You turn the cooling off. I normally will use a 10 or possibly a 12 millimeter spot size. And I normally do the first treatment at probably 12 joules per centimeter squared. tend not to go higher than 12 in the first treatment because, as you saw from the pictures, we can get a lot of erythema and there's a lot of heat buildup. But when you come to the second treatment, there is less pigment, so there'll be less absorption, so there'll be less heat and therefore less erythema. So at that stage, you can think about increasing your fluence.
And I have someone else asking for treatment guidelines for the Alexandrite.
For on the gentle series, I'm assuming. So what we
Yes.
can do is, yeah, we can email, probably the easiest thing.
I think so. Yes, let's do that.
Yeah. So if we've captured the email, then we can email you a copy of the guidelines.
I also see another question on how to download the webinar. This will be recorded and we share with you 1 or 2 days after the event.
Perfect. I'm just
you
skipping
get a
through.
lot of compliments, Hamish, for the excellent webinar. I see one other question for the in Fitzpatrick 5. What is the endpoint of treating with 1064 at 0.7 joules?
You do not see a great deal of clinical endpoint. You don't, and you certainly don't want to see any frosting when you're treating post-inflammatory hyperpigmentation. So what I would normally say is, if the PIH is quite dark, I would use lower fluences. If it's a little bit light, so 0.7. If it's lighter, I would go 1. And I have in 1 or 2 cases gone as high as 1.3 as my fluence for the lighter colored PIH. But remember, just a single pass. And you're not looking for erythema or frosting as an endpoint, because we don't want to deliver too much energy to actually cause that inflammatory response. Because if we get that high inflammatory response, the danger is that we're actually going to increase the pigmentation in the PIH.
Thank you, Hamish. These were all the questions.
Okay, there was one more.
Yes, I see that just coming in.
So there was one about treating with hydroquinone. I think if you're trying to treat darker skins, it depends on the wavelengths you have available. So for darker skin, yeah, it may be a consideration to use hydroquinone. So you're removing some of the, in effect, the surrounding pigmentation, which makes it safer. So I have a VL2 applicator. Can I use it on skin type 4? I'm not sure which wavelength that applicator is, whether it's 530 or the 555. So I'd need more information on that one. It's 530. You can, but just be a little bit careful when you're using a 530 on a skin type 4. It is safe, but just think about lowering your fluences when you're treating skin type 4 with a 530. The 555 would be safer because with the absorption is then starting slightly deeper in the tissue than it would with the 530. Okay, I think have we done them all? I think. Did I miss anything?
It looks like it, Hamish, but if we miss one, we can come back via email.
Yes, absolutely. Okay.
Thank you all.
Thank you very much, everybody. and enjoy the rest of your day.
This is the end of the webinar. Thank you, Hamish.
Thanks. Bye.